Good evening, and a very warm welcome to this third program in the patient education series of the MS Center at Thomas Jefferson University. A series that as this one would not be possible without the generous support of sponsors. And here you see the platinum as well as the gold sponsors of the program series. Their support is acknowledged. Neuromyelitis optica spectrum disorder, clinical and treatment considerations. The first question is obviously, how do individuals that are aquaporin 4 antibody, NMO antibody positive, how do they present? And you see this over here, that individuals can present with more than one of the cardinal features: optic neuritis, myelitis, Ariopostrina syndrome, brainstem syndrome, the diencephalic syndrome, or the cerebral syndrome. In an earlier section, we looked together at the MRIs of this. You also see that there is a slight imbalance, or there are some imbalances, how individuals may be presenting with these conditions that belong to different ethnic groups. Optic neuritis and myelitis are the most frequent presentations. The other conditions that I mentioned are quite rare. And from that point of view, it is also something that obviously the practitioners that see the patients with these more rare symptoms needs to recognize. At this point in time, because of the availability of the aquaporin 4 test, but because of the availability in the US of the cell-based aquaporin 4 test, many individuals are getting tested, even if the suspicion for neuromyelitis optica spectrum disorder is relatively low, because this test is available. And I think it's important then to note that obviously the antibody test really needs to be positive, not just marginally positive, before one can really establish a condition. And as discussed in the prior section, there are diagnostic criteria that require in aquaporin 4 positive individuals to have presence of one of the cardinal features and absence of lookalike conditions, so these need to be ruled out. There is an important difference in the behavior of neuromyelitis optica compared to multiple sclerosis. Many of you have heard in multiple sclerosis the term relapsing remitting multiple sclerosis, secondary progressive multiple sclerosis. Relapsing remitting is marked by relapses where afterwards the individual recovers function to a greater degree and then later on may have another attack. After years of going through the course, individuals may then have a more sliding course where disability accrues without necessarily having attacks. We refer this as secondary to relapsing remitting, secondary progressive multiple sclerosis. As you see on the left-hand panel over here, NMO is a little bit different in terms of that at the progression or disability progression normally occurs when the person has an attack. It's also likely that when a person has an attack, that there is actually a progression of disabilities that doesn't go away so that every attack leaves something behind. And this features that NMO attacks do not recover is an important feature when we consider the need to treat individuals. We need to prevent attacks because even more than in MS, there is always the capacity of an irreversible feature in patients that have had an NMOSD attack. Recovery is in many only partial. So that's a very important difference to MS. It's a very important difference also that prompts us obviously to be very vigilant with patients that have neuromyelitis optica. So when we look at the differences between neuromyelitis optica and multiple sclerosis, in MS, attacks can be mild or severe, but there's a whole mixture. In neuromyelitis optica, attacks are often severe. Initially, the brain MRI in neuromyelitis optica can be normal. Later on, there can be some changes, or if there is one of the rarer presentations. But obviously, in multiple sclerosis, we look specifically for the lesions. If the spinal cord is involved in neuromyelitis optica, it's often involved over long segments of the spinal cord, not in drop-like little lesions that are often the feature of multiple sclerosis. Equally, the cerebrospinal fluid, if a lumbar puncture is done, shows very often a significant rise of inflammatory cells. And oligoclonal bands that are usually present in MS are frequently absent in neuromyelitis optica. And as mentioned and reiterated here, neuromyelitis optica, 9 out of 10 patients are women. In MS, there is a preponderance of women, but it's only, the ratio is only 7-3. So 70% of newly diagnosed patients are women. And as mentioned, a very important feature of NMO antibody-positive neuromyelitis optica is the presence of the anti-aquaporin 4 antibody that, as I mentioned, should be tested with the best available test. And in individuals where, for example, plasma exchange or IVIG was used, or in individuals where one isn't sure, it is quite appropriate to repeat a NMO test several months after the initial test to ensure one result. With the availability, with the discovery of the neuromyelitis optica antibody test, another thing has happened, and that is that one actually had an anchor from which to start to study the pathology and the important steps in the pathology of neuromyelitis optica spectrum disorder. With the recognition that an antibody plays a role, obviously cells that produce antibodies, the B cells, came into focus. On the other hand, it also became into focus that what ultimately attracts the inflammation to where the anti-aquaporin 4 antibody binds to the surface of astrocytes, the whole cascade of events, the complement cascade, plays a role that this is also a potential target. In addition, it was recognized that when these processes are ongoing, that there is a significant inflammatory response, which gave development, or which gave an emphasis to also look at very specific inflammation markers and perhaps their blockage. I mentioned that investigators at Mayo discovered the presence of the Neuromyelitis optica antibody in 2004. And fast forward to 2019 and 2020, so about 15 years or so, we had the approval by the regulatory agency of 3 agents for the treatment of aquaporin 4 positive individuals. That these 3 agents belonging to different modes of action. One, blocking cytokine or the response to cytokines, the interleukin-6 receptor. One, blocking the complement cascade, and one affecting the cells that are involved in the regulation, the B cells that are involved in the regulation and in the stimulation of the antibody production. So think about this in a relatively short period of time. Thanks to the discovery of the aquaporin 4 antibody, specific treatments were available for this condition. Obviously, before these treatments were available, other medications were used for several years for the treatment of neuromyelitis optica. And looking at the population of patients, there are individuals that have been for quite some time on these other medications that are not specifically indicated for neuromyelitis optica, but have enjoyed relative disease stability. So we have 3 treatments that are approved for patients with aquaporin 4 positive NMOSD. In the world of the individuals with aquaporin 4 negative NMOSD or MOG antibody disease, that is, the picture at this juncture is still a little bit different. There is an interest in clinical trials or to see whether which agents would be helpful in MOG antibody disease, but right now we are working with the medications that are true and trusted, but not indicated and not specifically studied in the condition, but for which there is experience in the field. Let me touch on 2 additional or 3 additional considerations over here with neuromyelitis optica spectrum disorder. The first one is a very important difference between MS and neuromyelitis optica, and that is the point that I view pregnancy in neuromyelitis optica spectrum disorder as a high-risk pregnancy, where in the vast majority of individuals that have multiple sclerosis, I do not consider MS as a high-risk condition for pregnancy. The reason for that is that aquaporin 4 is not just expressed in the brain, but it can also be expressed in the placenta. And with that, in NMOSD, aquaporin 4 antibody positive NMOSD, the antibodies, the inflammatory response to the antibodies can interfere with normal progress of the pregnancy and can lead to miscarriages. So neuromyelitis optica spectrum disorder, when somebody wants to get pregnant, this should be probably a planned pregnancy, and there should be a team that helps that person to go through pregnancy, because the second consideration is also that there is a higher risk for preeclampsia. It's not a very high risk, but it's a higher risk, and monitoring is always important. Important is also to note that neuromyelitis optica can occur in children. At that time, it's very often part of a more diffuse disease when individuals present. It can present as ADEM, as acute disseminated encephalomyelitis. Again, important to note that in children, NMOSD can present differently, but the treatments, the acute treatments for an attack are quite similar. Neuromyelitis optica and vaccinations. Obviously, we come out of 2 years where vaccination has been top-line discussion. There is less information on neuromyelitis optica and vaccinations. However, individuals that are on disease-modifying therapy for neuromyelitis optica, non-live vaccines are generally considered as safe. Obviously, this is a point to discuss with the healthcare providers that you may be seeing. It's also very important to note that infections or infectious diseases in neuromyelitis optica positive individuals may have some additional considerations and should be prevented. So from that point of view, it's very important for individuals with neuromyelitis optica to receive the appropriate non-live vaccines and live vaccines under close observation. A point perhaps, because neuromyelitis optica is a rare disease, and I have mentioned the word of approved or not approved, but experienced. Several terms that we have very often. One is very important is formularies. That is what an insurance pays for. We also have the concept of step edits. Step edits means that the patient has to use one medication over another, dictated by the insurance. Many states at this point in time do have rules and regulations, laws on their books that make it illegal to have step edits for conditions such as neuromyelitis optica or MS. The Commonwealth of Pennsylvania currently doesn't belong to this group of states, but legislation is under consideration. Certainly a point where advocacy from the point of view of concerned patients and their families certainly wouldn't be wrong. Grandfathering is when a medication is no longer formulary of an insurance company, but the patient that is on that medication may be allowed to stay on that medication. Unfortunately, this rule is not always followed. And so another very important point, obviously, considerations that if a patient is stable on a certain medication, that the patient should be allowed to stay on that medication. So this is kind of my soapbox slide to make clear to you that as an individual or a person concerned with a condition like neuromyelitis optica or MS or any chronic disease, you need to create a voice for yourself in the political environment to or support such efforts. As you obviously see from what we discussed with neuromyelitis optica, this needs a team of individuals. And so it's important that patients with a rare disease such as neuromyelitis optica, or for that matter, MOG disease, are seen in a team that has experience with these conditions.